We are among those who have waited long and borne too much while waiting for that change. So it's in that spirit of understanding that times like these are the opportunities for us to make a difference that I want to speak to what NAMI California has been doing in the last year. And in that vein, I'd like to remind you of the mission and vision of NAMI California. I'm just going to read that mission and vision statement. NAMI California is a grassroots organization of families and individuals whose lives have been affected by serious mental illness. We advocate for lives of quality and respect without discrimination or stigma for all our constituents. We provide leadership in advocacy, legislation, policy, development, education, and support throughout California. NAMI California is the leading organization of individuals working with mutual respect to provide help, hope, and help for those affected by serious mental illness. That's a really solid place to stand on as we do our work. And I'd like to share just a few things we've accomplished in this last year, even as we, like all of you, rise every day to continue to work, to live, and to love in the face of all that has happened this year. First, a little bit about programs that we have, some highlights and achievements. In 2019 and 2020, we provided training to more than 50 trainers and facilitators through NAMI California signature programs. We've trained nearly 100 individuals through our family and peer support specialist training and partnership with OSHPD, and provided cultural competence training to more than 200 individuals and providers across the state in partnership with the UC Davis Center for Reducing Disparities. Through our NAMI on Campus high school program, NCHS, we trained staff and students from 26 high schools in Stanislaus, Los Angeles, and San Bernardino counties. This fiscal year, we developed a partnership with the Stanislaus County Office of Education to provide training to all high schools in the district to form their own NCHS clubs as part of an innovation grant from the Mental Health Services Oversight and Accountability Commission. To date, there are 65 active clubs in 21 counties, reaching roughly 117,000 students. NAMI California works in partnership with NCHS experts from NAMI affiliates in San Diego, Temecula Valley, Marin, Sacramento, Pomona Valley, and Kern to support current and prospective clubs. As a result of the COVID-19 epidemic and pandemic, and this is going to be something that you'll see evidence of this throughout my remarks, we embarked on a new virtual reality of online support and services, working with local affiliates to support their efforts to provide local education and support groups. Our staff is currently working on a plan to coordinate more than 40 online state trainings with the goal of training more than 450 new teachers and facilitators across the state. Now that's a big impact. Also, we've been hard at work executing on a comprehensive outreach effort, recruiting and training for NAMI on-campus programs across the state through a new partnership with Blue Cross, or with Blue Shield of California. So what's next for the programs? We would like to thank, first of all, Mental Health Services Oversight and Accountability Commission, the California Mental Health Services Authority, for their continued partnerships. And through their support, we're going to be continuing program trainings across the state. We're going to be coordinating statewide dissemination and outreach, coordinating local awareness events, increasing the number of NCHS clubs, as well as continuing our partnership with NAMI National to pilot the Family and Friends seminars. Now, overall project outcomes for the 1920 or fiscal year 19 and 20. Through our peer and family support trainings, we trained over 220 program leaders, as I mentioned before, who will reach an estimated 11,000 individuals statewide. And in the past year, on average of 4 new clubs every month at our campus, our NAMI on campus high school clubs have formed. And they're going to be touching over 62,000 students with information on mental health and stigma. That's remarkable and could be seen as 48 steps further down the path to the day when stigma is just a memory. We also produced a streamlined training of trainers process to speed the spread of this important work. Community engagement, another area of important work for NAMI California. In 2019 and 2020, we continued our work with the Office of Statewide Health Planning and Development, OSHPD, where we engaged peers and family members from diverse communities into the workforce. Family and peer support specialist programs is a great story. NAMI California partnered, for example, with 4 affiliates to serve as regional hubs for career counseling, placement, and support. NAMI Contra Costa and San Joaquin coordinated the Northern California region. NAMI Mount San Jacinto and San Diego focused on the Southern California and Central Valley region. And NAMI San Diego also maintains the curriculum and co-facilitates training. NAMI California and its affiliates proactively engaged county behavioral health departments and regional NAMI affiliates to promote and place peers and family in the public mental health system. For example, the San Joaquin Wellness Center is supported by the Mental Health Services Act, and they made an investment through San Joaquin's County Behavioral Health Services to support this work. We've been active and successful in placing peer family support trainees in paid and volunteer positions across the state. And just a few examples include the Wellness Center of San Joaquin, where we placed a lead peer recovery coach, NAMI Sacramento for a connections facilitator, the Imperial Valley LGBTQ Center, peer support specialist, and NAMI Ventura, peer assistance and warm line volunteer. We continue to engage diverse communities through our multicultural symposium, and we had nearly 20 leaders from across the state present their work, including their successes, challenges, and best practices, and over 200 attendees throughout regional and annual multicultural symposiums in this last year. We continue to engage diverse communities through multiple pathways, our multicultural symposium, focus groups, and by seeking their input through the mental health survey that we put out every year. Cultural competence and responsiveness training toolkits are available, and the Mental Health 101 program presents across the state, including San Bernardino County, for example, where they received the first ever Spanish Mental Health 101 training with 30 attendees who were certified. We also learned from the Community Voices platform on our website and other social media. And in partnership with the RAND Corporation, we provided Latino Catholic faith community projects in Southern California with Mental Health 101 Spanish presenter training to conduct various presentations and to measure and determine the impact of the program on this community. A remarkable body of work. And we did that work with support from RAND to help overcome some of the restrictions that arose from the COVID restrictions. So what's next for community engagement? NAMI California will continue to engage participants in the workforce, as well as develop and promote positive messaging and strategies to disseminate mental health information, coordinate regional symposia, and to gather stories of consumer and family members who highlight throughout the year. We will collect data, always important, on the unique mental health needs of diverse racial and ethnic communities and family members and caregivers. This is going to be reported for the final OAC Year 3 annual State of the Community reports. That data collection will include focus groups, listening sessions, case study interviews, and stakeholder surveys. We will also be, of course, continuing our regional and annual multicultural symposia in an effort to reduce officer-involved shootings and other crises like high rates of suicide among officers. We have partnered with the Commission on Peace Officer Standards and Training to develop a curriculum for NAMI COPE, which is a peer support group for law enforcement working to assure and understand their own mental health, creating a safe space to heal from trauma and to cultivate officer wellness. Advocacy, very important to the work of NAMI California. In the 2019-2020 year, NAMI California surveyed its members across the state to identify trends in policy and access to healthcare. and the availability of local supports and services for individuals and family members. Our advocacy priorities were based on that kind of member feedback, as well as our own strategic plan and policy platform. Advocates were activated to support both local and state advocacy efforts, including state priorities on access, peer certification, and the state budget, including ongoing efforts to preserve safety net funding. Additionally, more than 25 NAMI advocates attended the Assembly Budget Subcommittee in December of 2019 to address the proposed MSHA reform, sharing their personal stories with state lawmakers and agencies. NAMI California also conducted 3 in-person regional meetings in Yolo, Coachella Valley, and Contra Costa County. Attendees were connected to local decision makers, including county behavioral health staff. Further discussions and subsequent action plans were tailored to regional and county needs, including issues of criminal justice, homelessness, and access to appropriate services. Lastly, NAMI California launched a new effort to host a series of town halls designed to connect members and affiliates to state leadership. The first town hall with County Behavioral Health Directors Association focused on the local and state response to the current public health crisis and the MSHA funding forecast. 74 individuals joined, participating in an active listening session on the experiences of family members and individuals, that voice that we know is so important, as they sought to access care at the local level. The second town hall with the Department of Health Care Services included information on Cal Hope disaster relief efforts. In that case, 54 participants engaged in a listening session and Q&A with Department of Healthcare Services Deputy Director Jim Kooler. NAMI California's advocacy team works every day to fight stigma, provide support, educate the public, and advocate for better mental health care for all. Every day, the movement grows stronger, and the priorities include access to treatment, housing, crisis services, including new COVID-19 protocols, criminal justice and forensic issues, family involvement in treatment, services, and support for all ages. They have an ambitious year planned as well. They plan to make sure that we are actively engaged in reaching underserved communities through the legislative process, through membership and partnership with the California Healthcare Foundation. Staff will facilitate a series of focus groups on priority topics as identified by those outreach efforts and engagement with affiliates and members. Future town hall topics include confirmed participants such as the Department of State Hospitals, Council on Criminal Justice and Behavioral Health, the Mental Health Services Oversight and Accountability Group, the Department of Managed Healthcare, the California State Association of Counties, and the California Pan-Ethnic Health Network. Our affiliates, of course, are an important place where we do work, and 2 accomplishments are among those that I'd like to highlight. We had our first annual Affiliate Leadership Symposium, the purpose of which was to bring affiliate leaders together for one day to learn how to grow and sustain their organizations. Our ALC committee, with support from NAMI California staff, put together a compelling agenda for our first annual symposium, and we received strong feedback from the affiliate leaders. Affiliate leadership calls. Due to COVID-19, we've had to change the way we connect with our affiliates, so we began facilitating monthly calls to cover COVID-19 updates, exploring the status and course of the pandemic, including its impact on affiliates, families, and businesses. NAMI California updates, reviewing upcoming activities and events, as well as guidance on and technical assistance for affiliates through the transition to online platforms for local education and support groups. State training focused on implementation of national guidelines, including how to simulate in-person activities in an online space. Online Zoom setup and support, first assessing local needs by collecting affiliate information on readiness for online programs, providing guidance on platform setup, including steps for how to maintain anonymity, and ensure privacy of support groups, advocacy updates on state and local policy issues, budget forecasts, and specific issues including updates on MHSA reform, LPS audit, and the MHS OAC rules of procedure, and the use of MHSA funds to support COVID-19 related issues. Long story short, it's been a very busy year with an incredible amount of work accomplished. As we complete this year, we acknowledge that all of you make us who we are. NAMI California is committed to continued work with you, our members and affiliates, to increase the NAMI presence and impact statewide. Thanks to you all, and here's to our future together. Now, it's my pleasure to introduce our keynote speaker, Dr. Sandra Hernández, who is a graduate of Yale University, the Tufts School of Medicine, and the certificate program for senior executives in state and local government at Harvard at their John F. Kennedy School of Government. A great pedigree, great education. We're glad you brought it from the East Coast back here for us to enjoy. Sandra is the president and CEO of the California Healthcare Foundation, and prior to joining CHCF, she was the CEO of the San Francisco Foundation, which she led for 16 years. She previously served as the Director of Public Health for the City and County of San Francisco, and has also co-chaired San Francisco's Universal Healthcare Council, which designed Healthy San Francisco. It was the first time a local government in the United States attempted to provide healthcare for all of its constituents. In February of 2018, Sandra was appointed by Governor Jerry Brown to the Covered California Board of Directors. And in December of 2019, she was appointed by Governor Gavin Newsom to the Healthy California for All Commission, which is charged with developing a plan to help California achieve a healthcare delivery system that provides coverage and access through a unified financing system. She also serves on the UC Regents Health Services Committee and the UC San Diego Chancellor's Health Advisory Board. Today, Sandra will discuss the significant mental health crisis in California, comparing before and after the pandemic. She will also discuss positive trends and solutions that have been impactful in improving mental health care in California, specifically reaching those in need more now than ever. And with that, I'd like to hand the mic over to Sandra.
Thank you, Pat. I appreciate that introduction. Good morning, everybody. Pat, let me just thank you for your leadership and service as chair of the board of NAMI. Governance matters so much in terms of an organization's ability to reach all the networks it's trying to reach. So thank you for what you do alongside Jessica and team. Really an extraordinary list of accomplishments over the last year. So congratulations, NAMI, for all of that amazing work. It's really, can I maybe get the first slide here? Let's see if I can pull that up. Let's see, I think this is it. And let's see, this goes to, okay, can everybody see that?
Yep.
Just one slide? We good?
What we're seeing is the slide, and then the other slides off to the left.
Okay, let me see. If
you say start from the beginning, there's a little up to the left. You could
right up here, right?
No, down underneath file. There's a from the beginning, and you can start
there it is.
Over on the left.
On the far left. There you go.
Good.
Ah,
okay.
Beautiful.
Good. Well, you know, I do think we're at an incredible pivot point as it relates to mental health in California for all sorts of reasons, many of which Pat already mentioned. And so, you know, as I think about this, I really think about it as a new dawn for mental health care in California. There's much more public recognition that mental health should be taken as seriously as physical health. There's extraordinary leadership at the state, which I'll talk a little bit more about. And of course, the pandemic has created an unprecedented demand for mental health services. NAMI plays a very unique role in California as it relates to education, advocacy, and policy, and really, I think, has brought the public well ahead of our policymakers on this issue. So let's talk a little bit about pre-pandemic, which seems like eons ago. This was from a poll the California Healthcare Foundation did back in 2020, pre-COVID. And the question here was, again, this is a policy poll. How important do you think it is for the California governor and legislature to work on each of these areas in 2020? And as you can see, mental health was at the top of the list, making sure that people with mental health problems can get the treatment they need. It was more important than lowering prescription drugs. It was more important than how people pay for health care. And I think what it shows mostly is that the public has been aware well ahead of policy and politics on the issue and importance of mental health as a policy and access point of view. This is from a survey that we did back in 2018. And really what it shows is that of the people who sought treatment for mental illness, fully 63% did not receive mental health services that they sought out and needed. This is data through 2015, which was the most recent data that we had at the time. I think some of you may be aware that a number of our sister healthcare foundations, along with the California Healthcare Foundation, convened a statewide commission to look at the future health workforce needs in California. Pat participated on it, and I call it out in part because it was a futuristic look at what the needs are for our healthcare workforce. Pat mentioned this in a number of his remarks. But it's noteworthy that in 10 years, California will only have 2/3 of the psychiatrists that it's estimated that we need. And that's just for psychiatrists. CHCF, as a result of this report and its recommendations, is currently partnering with the University of California healthcare system to launch an online training program for psychiatric mental health nurse practitioners. And the goal is to have 300 of them trained by 2025, really just trying to add to the spectrum of behavioral health and mental health providers that we need in California. And I think it's important to note CHCF spends the vast majority of its work and time thinking about how to get care to people who are most disenfranchised, be it because of type of illness, but also just because of poverty and income status. And as you can see, there is a disproportionate need to address care for serious mental illness in California, particularly for people who live below 100% of federal poverty, as you can see from this study, which is from the California Budget Policy Center 2020. Again, a really striking variance. People who have more resources tend to be able to navigate a limited system to be able to get care, and people who are much poorer have much harder access in that regard. That's true among Californians. It's also true among children, as you might imagine. And again, this is a statement of an unmet need for a population that is really struggling. I'll share, as Pat has, that we are all family members in one form or another that deal with family members and friends loved ones who are struggling with whether it's depression or anxiety or a serious mental illness. We have a family friend that today is struggling with a child who's really, really profoundly depressed due to all kinds of issues, both COVID and non-COVID. And certainly there's a lot of conversation today amidst the pandemic about the impact of children and young people not being in schools and not having sort of the support system that to a certain extent does exist there. I wanted to spend a minute to call out how important Medi-Cal or Medicaid nationally is as it relates to paying for healthcare, mental health care in our country and in our state. This is from a project that we did back in 2018, California Healthcare Foundation. All these reports, by the way, are on our website. And this really looks at mental health in California based on payer status. And as you can see, fully a third of payment comes from our Medicaid program. This is a program that covers 13 million people in California and is a program that, as you all know, is jointly funded both by the federal government and the state government, and also that California, by virtue of its Medicaid expansion as part of the Affordable Care Act, was able to expand Medicaid quite significantly. And so it's a very important program to be able to keep an eye on from a policy point of view. I think most of you know that the ACA has an issue before the Supreme Court that's being hotly debated literally as we speak. But the protection and the importance of this program as a payer for mental health services just really cannot and shouldn't be underestimated. And I think as we think about mental health and its access, a focus on these public programs is really critical. On this slide, this just shows you the use of Medi-Cal specialty mental health services for adults and children from 2012 to 2015. And as you can see, that role of Medi-Cal paying for specialty mental health services has been growing quite significantly. And 2015 is the latest data that we have, and I suspect if you were to project that out to 2020, that has grown yet more. So really important to understand the role of the Medicaid program as it relates to providing for services for adults and children with specialty mental health needs. A lot of conversation in the state around the epidemic of homelessness that we find both in our urban areas as well as in our suburban areas. This has been a great focus of the state legislature. It's been a focus of the governor. And 67% of people living in the streets in LA were reported to have or observed to have had a mental illness or substance use disorder. And I do think there are myths about, cause and effect, but it's quite clear that if you're poorly sheltered, unsheltered, living in crowded conditions, or living on the street, that your risk for mental illness and or substance use disorder grows quite substantially. And therefore, as we think about the policy around how we address homelessness in the state of California, I think it's really important for us to make sure that we understand we're not going to solve homelessness without addressing the mental health needs of this population and vice versa. It's really hard to imagine addressing our homelessness crisis without also addressing mental health. Well, we're in a pandemic which feels like it's been with us for a very long time. And spend a moment looking at signs of depression. This is from a study that was out of JAMA. It was done by Boston University. And it was striking, when there are traumatic events, often you'll see a doubling of depression rates. But this study showed that there was threefold increase of rates of self-reported depression since the beginning of the COVID-19 pandemic. Many reasons for this, as we might imagine, including illness itself and risk of COVID and fear of COVID, family members who are struggling with COVID infection or at risk of it, not being able to see loved ones in hospitals or in homes. There's a tremendous amount of burden and stress on the workforce itself, which at the outset really was not even well equipped to protect itself against COVID in terms of PPE. Enormous numbers of job losses all across the country. You have parents and teachers who are worried about sending their children back to school, both wanting to send them back, but also wanting to make sure that they do so in a safe way. And then there are all kinds of renters that are facing eviction and homeowners who are facing foreclosure. So many, many reasons that lead to this threefold increase in depression that we have seen since the beginning of the pandemic. And it's important to note this was true across all demographic groups. And, you know, haven't really discussed the race conversation that we're having in this country. Likewise, a reckoning of racism in the country that I think likewise is a pent-up sense of something that we as a country really need to also address. But in this study, all demographic groups showed an increased rate of depression since the pandemic began. It's especially true among young people. Reported symptoms of anxiety and depression were highest in the age group of 18 to 29. This is interesting for a couple of reasons. One, this is a population that, as I showed earlier, at baseline doesn't get very good access to care. But also this is a population that normally would be socializing in the world. We're asking them mostly to stay home. I know this firsthand. My 20-year-old daughter, you know, you're in college, you need to come home, you're going to be virtual, don't go out with your friends, wear a mask. I mean, there's just a tremendous amount of anxiety, both about the illness and its relationship to family members, but also just about their future. What does the future hold? What's certain about it? And I can just attest to the sleep disorders that are associated with this and the anxiety and depression that we're seeing in particular in this age group. You also, if you look at the media, there's a lot of conversation about COVID being relatively asymptomatic in this age group, and yet asymptomatic folks who have COVID are a very high risk of being transmitters of this particular infection. And I think that adds an additional burden of anxiety and depression as we're seeing in young people during this pandemic. This is just noting that in addition to anxiety and depression, we're also seeing deadly overdose spikes during the pandemic. And also we've seen increased rates of attempted suicide. And so many serious warning signs that COVID-19 is adding significant mental health stressors and burdens for our families and our loved ones all across the state, really all across the country. These are a couple of articles from different news sources. So as Patrick said, I do want to talk a little bit about positive trends and what's happening and what's hopeful as we confront this pandemic and hopefully get to a place where we're better able to manage it. CHCF has been working for some time in really trying to integrate care such that people who have a serious mental illness and also have some chronic condition really are able to get care in an integrated way where data is shared, specialists can speak to one another, and we don't put any burdens either in the treatment of their physical health conditions and chronic conditions, or with regard to getting access for severe mental illness. This is an area that we've been working at now for 3 or 4 years. Have a lot of folks that are both interested in how we do this better. Care integration often also means financing integration. It also means really the sharing of data and making sure that we, in fact, get providers to understand that people have all of these conditions together, and our delivery system ought to be able to address it in a way that both its payment and its administration is simplified for these patients and their family members. Pat talked a lot about online platforms. This is probably the biggest game changer in access to mental health, which is the proliferation of telehealth and all kinds of platforms associated with it. California Healthcare Foundation Board recently approved a $6 million grant to really help all of our safety net providers across the state get capabilities and technical knowledge in how best to do telehealth. And by far and away, our federally qualified health centers, our public hospitals have used telehealth as a means by which to reach out and do mental health support during this time. This is a very consumer-friendly way to approach mental health. You know, Pat talked a lot about in his remarks how important NAMI's work has been in reducing stigma. Telehealth really has the advantage that it can reach you wherever you are, not necessarily requiring that you go somewhere to get care. And so we see telehealth and the huge increase in usage of that as an enormous benefit, and one that we think is with us for the foreseeable future. I don't think you know, this will be a platform that we'll learn from. There's a lot of innovation in this space that we're also interested in supporting and learning from. And I think in many ways has been a bit of a lifesaver at a time when we and the entire world pretty much has gone virtual. Pictured here is Karis. I think she's well known to NAMI. You know, she's been very active in the LA County Department of Mental Health. Important, the peer support specialist that Pat mentioned was a very important bill that NAMI endorsed and that we are incredibly excited about trying to figure out how to continue to support. And I just want to call out Pat's comment about how important language access and cultural competency is as we design these programs. And these peer allied health professionals really do give us an enormous opportunity to think about the mental health workforce, particularly in Spanish-speaking communities and communities that have a lot of cultural nuance associated with mental illness. And so really the opportunity to continue to expand our cultural and linguistic capabilities in this peer support program, we think is a very exciting new bill, and we look forward to being supportive in expanding it and evaluating it. Pat mentioned a number of places across the state where this is in play, and we think with that bill newly signed, we should see a lot more peer allied health professionals moving forward. Talk a minute about parity. SB 855 would repeal California's mental health parity law and replace it with the requirement that health plans and disability insurers cover medically necessary treatment, both in mental health and in substance use disorders, under the same terms and conditions as other medical conditions. NAMI endorsed this. We think this is a very important effort. You know, a lot of conversation early on during the ACA about parity, but there was really no teeth in being able to enforce it, or even to collect data on it. And I think the new power to enforce the rights of mental health consumers is an extraordinary opportunity that we have in California that we will want to take advantage of fully. And we were very excited that NAMI got behind this effort as well. You know, I think leadership really does matter. You know, for the first time, we have a governor who I would say really gets it. It's hard to think of a single policy issue that is not impacted by the state of mental health care. This was the direct quote from the governor. And I fully expect that, you know, as we continue to come out of the pandemic, that mental health care will continue to be a policy matter, both for the governor and his administration, but also for the legislature. And really, this is something that we need to do in conjunction with families, in conjunction with organizations such as NAMI, in particular NAMI in California, in order to really give voice to consumers and family members and really put input into the policies that the governor and the legislature will take into account. So I'm excited. I think it's hard to look at any silver lining in the midst of the pandemic. And yet I think the day for mental health, for consumers, for advocates, for policymakers, and for our workforce, if ever there was a moment in time when we would say mental health is an issue that we cannot ignore, no matter what other issue you're trying to solve, this is that moment in time. And California Healthcare Foundation stands with NAMI in the work that you're doing, and look forward to a year in which we implement some of these new bills that have been signed, evaluate them, make sure they're working well, that we are able to fight for Medi-Cal and Medicaid, and that we really continue to focus on growing the workforce that we need to meet the many unmet needs that we've seen today. So with that, I'll stop, Pat, and give it over back to you. Thank you.
Thank you, Sandra. That was great. There were some really pretty remarkable statistics. The statistics on the impact of COVID-19, especially in the younger population with regards to depression and anxiety, is pretty remarkable. And I'll have a question or two for you. In fact, what I would like to have everybody in the audience know is that if they have questions that they'd like to submit, we'll do the best we can to get the time to do that. On the WOVA application, you have a chat function that you can use to submit those questions, and they'll be fed to me so that I can ask Sandra. So please feel free to submit. I do have one that actually touches on some work that has been done in California I was connected with and you mentioned, and that has to do with the workforce. You mentioned the profound impact that telehealth has had on the ability to make that connection with a reduction in the barriers between patients and therapists. But of course, there aren't enough therapists available. And you know, what is your sense of the time, energy, and investment that we'll be making in California in particular to help to make more therapists available?
Yeah, it's a really good question, Pat. You know, I think there's a couple of points to be made there. One is that a lot of the therapists that exist in California are in private practice. And really aren't in the formal delivery system in any significant way. And you know, we find CHCF does most of its work thinking about system design and how those systems operate and how you change them. And I gotta believe that part of this issue is really the financial incentives to participate in public programs such as Medicaid and the like. And so I think payment and payment reform is a huge part of this. If we think about why people don't go into psychiatric care, psychology, and the like, often it's because of the same stigma that has existed with regard to treatment about our delivery system, our training systems and training programs. So, you know, we think that this entire cadre of workforce in behavioral health, you need to think about how we incentivize financially both that people go into the field and that people who have those credentials today, we find a way to bring them into these platforms and telehealth platforms in a more you know, systematic kind of way. So it is not, you know, as you know, the path through medical school into psychiatry is a very slow one. Don't think we'll meet our needs solely that way. But I do think that we should think about making sure that the payments that were put in place under the CARES Act that allowed for telehealth to really take off in the state, that those are sustained and they're done so in a way that really incentivizes providers to get into these programs where most people seek their care.
Yeah, great insights. That, you know, the small silver lining of what's been happening is that it creates much greater visibility to some of these challenges and forces innovation. And as you suggest, we need to be able to capture and hold on and sustain some of that dynamic that is pushing us into new spaces right now that otherwise we would have continued, I think, in some ways to acknowledge, admire, and do nothing about, or do things quite slowly.
Yeah, I think that's right, Pat.
You know, getting back to the impact that this has on the youth in the country, you know, yesterday during the conference, we heard the statistic that in the last 30 days, 1 in 4 people in the younger age groups had considered suicide. First is that consistent with what your statistics might show, or what you've seen? And second, what are the ways that you see as opportunities for us to reach out and actually have that conversation with the community?
Yeah, Pat, it's very consistent data that what we've seen nationally. The study that I cited found similar rates. And, you know, I would say a couple things. One is, talking to a 20-year-old, let alone her friends on FaceTime, you know, one of the things that has struck me is they're also looking at adults in their family and loved ones to sort of be hopeful about the future, about their future, as well as about, you know, the future of the country, the future of the planet. You know, I think it's important for us to understand the role of family and what messages we send out with regard to some sense of future and hopefulness and certainty in a time with great uncertainty. I can tell you that my daughter listening to me on Zoom has not been good for her mental health by and large. So I'm deeply aware of all of our roles in this. You know, I do think that there is a need for peer support among young people. And that's not just within their bubble and the people that they knew pre-COVID. And so really trying to figure out where we can send young people for all kinds of things, whether it's meditation, whether it's yoga, whether it's a safe way to be outdoors. You know, I think we need to think about sort of building resilience in a population that quite legitimately, given their age and where they are in their life, and normally would be exploring all kinds of activities, really just understanding what their needs are and really thinking about a continuum of set of wellness and family supports that we can put in place for them. There are many, many sites to be found and organizations that are working to build them. I think the biggest challenge, of course, is making those connections for them and making sure that they know that there is support both within families, but also within their peer group more broadly. And so the peer support work that NAMI has gotten behind, you know, I think it's so important to scale those programs and to get into communities that have such poor access to those kinds of programs today.
You know, you brought up another important point, and it was one that you had as a part of your remarks. COVID has actually accentuated the disparate impact of so many different elements of society and access to care and access to other parts of what help to assure well-being that it has had on communities of color. You know, the proportion of essential workers who are members of the communities of color, the proportion of fatalities in the country from COVID that are disproportionately borne by those communities have highlighted and accentuated something that has been true for a long time. It's just that it's been inapparent enough so that we could kind of ignore it, unfortunately. And I'm curious about how those issues, along with what we know about our own position in bringing individuals and families with lived experience into the forefront, how do we see that unfolding for us, making those voices more prominent and driving a different way of approaching these issues in the future?
It's a great question, Pat. Lot in there. You know, I think it's important just to recognize we're a very diverse state in the state of California. If you just look at high school seniors, for example, 56% of them are Latinx. And if you look at COVID and the infection rates for COVID and the Latinx community, you see these enormous disproportionate impacts, both, as you said, because of essential workers, but also because of very crowded living conditions. And, you know, CHCF has been part of a philanthropic, you know, collaboration along with the state, very much focused on really hiring community health workers from within communities that are disproportionately impacted to help with some of the public health activities, education, testing, contact tracing, helping people, you know, to safely quarantine when they've been exposed. And, you know, I think we ought to look at our community colleges as a tool for that. These are places that exist all across the state. CHCF funded some years ago a journalism project in the community colleges as a way to create some expertise and really first person, first voice experience of lived experience, where journalists were taught to really describe their experiences in seeing mental illness. And it was an extraordinarily interesting project for us, really just to learn more about the lived experiences that have a cultural nuance associated with them. And so I think lived experiences is more important today, perhaps, than it's ever been. And particularly because of this disproportionate impact associated with this pandemic in very low-income communities, in the Latinx community, and the Black community. You know, we already have linguistic and cultural challenges in our workforce writ large. And so the lived experience of individuals who have experienced this, I think, is is an asset that we should cultivate and grow as a means to strengthen our mental health response as a state overall. It is, you know, we didn't talk about it a lot, Pat, but the other thing that your question triggered for me is just the race debate that we're having in this country, and how much that's been politicized. And so, you know, if you're in a mixed immigrant household in California, which many young children are, or you're a first generation immigrant, or you're a DACA individual, so much animosity. The description of COVID-19 as a China virus, and the untoward, stigma and hate that's been, tended to many folks in our Asian community. So I think those are all part of the environment that we're in today, and makes lived experience and your family's, configuration, and really how we think about building resilience really is, I think, going to rely a lot on tapping those experiences from a very diverse state. And we should learn, and evaluate how well that's worked, and lift up those things that are working. But lived experience is going to be an enormous part of coming out of COVID-19 and building our mental health capacity.
I couldn't agree more. And I've got one more question, and then we're going to make our transition to a brief break, and I'll have Jessica say a couple of words. But one of the things that's both exciting and challenging in all of this, especially as it relates to what we've seen with regards to students and the challenge of establishing connection for home learning and remote learning, and then also seeing the great expansion and extension of telehealth services into areas and populations that haven't had that available before. It also calls forward the question of those, for instance, the homeless, who may not have access to the technology, or children or families, or even sections of the state that don't have the kind of bandwidth for this to be able to deliver those spaces. And I'm excited actually by the possibility of creative experiments about how you bring the technology into those spaces so that people have access in ways that bricks and mortar just weren't possible for. So I'm curious about your reflections on that.
Yeah, I have a couple of reflections on it. First of all, universal broadband really ought to be commensurate with universal healthcare, right? I think the reliance that we have today for children to be on broadband, to be able to access education, and every child really deserving to have that education, really does compel us to do that. And there are philanthropic organizations for whom that is their sole mission. And it's interesting you raise it, because we had a very vigorous conversation at my board meeting last month on that very issue. I do think that we're seeing some very innovative ways to do that, to create that kind of technological platform. And the other thing I would say is, not unrelated to this, is that one of the things that has made COVID-19 so difficult to manage is all the fragmentation and information systems that we have. And there too, I see lining on that cloud, which is to say, people have begun to recognize that the very fragmented way in which we collect information and provide services, whether it's public health, mental health, or physical health, really just hinders us in our response to any of the above. And so it is a moment where, here we are in California with these enormous tech giants, and by the way, a stock market that continues to do very well on the backs of technology. It seems to me that we're at a moment in time of really trying to make sure that the technology that we have is one that is beneficial to both people's education, but also to being able to access the care they need in a more timely way. We spend an enormous amount of money in this state and in this country on bricks and mortar capital, an enormous amount. You know, I cite this fact often that we have a country that spends 18% of our GDP on healthcare. And when a pandemic breaks out, we don't have basic PPE for frontline healthcare workers. It is just one example of how we use the assets of our vast healthcare delivery system. But I think, you know, increasingly, Pat, I mean, you mentioned that, you know, I'm an advisory board for UC Regents, and one of the conversations that is being held there is how much of bricks and mortar do you continue to build as opposed to really thinking about the platforms that allow us to look at population health, look at wellness. And I think, again, this is this moment of reckoning about where are our priorities as a delivery system. And I think the days of come to us, and you even see commercials now about come back to the ER. Now, that said, there's a lot of care that's been delayed because of COVID that we should be concerned about. But I think on the whole, this is going to cause a significant refocusing of where we spend those dollars. And I was on a call the other day with one of our great healthcare systems in the United States who has a plan for doing really a virtual hospital for up to 30% of patients that currently come into an acute care hospital for hospitalization and doing that care at home. And so I think that's the new world that we're in. And I think that's incredibly exciting for what we're trying to do in the area of mental health in particular.
Couldn't agree more. Very exciting. Sandra, thank you so much.
My pleasure, Pat.
Time has moved very quickly, and you've taught us, taught me so much, made me even more grateful that you're in the place you're in, helping with these very challenging but exciting problems here in California.
Thank you, Pat. It was nice to be with everybody today. Really an incredible honor. And thank you again to NAMI and the entire team. You've had a great year, Jessica.
And with that, Jessica, I'm going to turn it over to you. We are doing a virtual round of robust applause for you, Sandra. So thanks again. And Jessica, you have a few words in transition.
Yeah, I cannot thank you both again enough for your time, your expertise, your partnership. We have not only learned so much from what the California Healthcare Foundation is able to release as public documents through all of, you know, the data-driven best practice work, but also really that partnership in making sure that families and people with lived experience are driving a lot of these policies. And so thank you so much for understanding and valuing the experience that we all hold. We always say we're experts out of our own experience, you know, and it's so true. And thank you for really taking the time to honor that for us. So with that, we have just a few minutes before our next group of speakers come to talk about just some kind of crisis situations we've gone through in California. Wildfires, of course, COVID, the racial injustice and really unrest that's happening here. And so we have some really great speakers to talk about not only at the state level, what is available for crisis response, but also what can be done through your local affiliates or at the local level to respond to various different crises as well. So we'll take a couple of minutes while we kind of transition our panelists over. Again, thank you so much, Sandra and Pat, for everything that you guys give to NAMI and for the work you do for California on a daily basis. So we had a wonderful morning session with Dr. Sandra Hernández from the California Healthcare Foundation. They're doing such incredible work in bringing our issues and using our voices to really drive and lead the change. My name is Jessica Cruz. For those of you who don't know me, I'm the CEO of NAMI California. And this session is going to really be about our disaster response. As we had mentioned before, you know, California, the nation, is really going through a lot of crisis right now, whether it's the pandemic, our racial unrest and injustice. And then here in California are wildfires and how all three of those impact our behavioral health and our mental health, our trauma, is really important for us to all be, one, aware of, and two, understand what resources are available, not only at the state level, but also what can we do and what is being done locally. So my job today is to introduce Dr. Jim Kooler. He is the Deputy Director of Behavioral Health at the California Department of Healthcare Services. He previously served as the administrator for the California Friday Night Lights. He's been a partner of NAMI through his service there, doing California youth development and health promotion. And now he is a partner of NAMI California in his role at Department of Healthcare Services. Welcome, Dr. Kooler, and I will throw the baton to you.
Well, Jessica, thank you so much for the chance to be with you today and to be with all of our friends across the state with NAMI. And I am excited to share with you some of the things that the Department of Healthcare Services is doing in partnership with our local efforts at the county level that you're likely already involved in. It has been an amazing 2020. It is a year that feels like a decade. And we are experiencing not just a single disaster, but layers of disasters. Whether it is the public health emergency of COVID, whether it's the social injustices, whether it is the politics that we are seeing, whether it is the fires that we are breathing, we are faced with layer upon layer of stress. And the result of that is really toxic on our physical health as well as our mental health. So we're fortunate that we are able to partner with FEMA, the Federal Emergency Management Agency, to be able to bring resources to California for a crisis counseling program. And the term counseling may be a little bit generous in terms of this project in light of what we normally think about when we think of counseling, which might be someone who is licensed or certified, though we really believe the power of peers. And with current legislation which just passed, which really puts more leverage behind the peer movement, we think that the Cal Hope project that we're going to talk about is a way to really bolster that effort. So in the FEMA world of crisis counseling, there are two phases of a program. There's the immediate services program, which is intended for the first 60 days after the declaration of emergency. And then there's a regular services program, which is intended for the next 9 months after that. And the purpose of crisis counseling is really to intervene and support people in that moment of crisis to help them find the resources and supports that they need to be able to navigate through to a more normal life. So it isn't intended to intervene to address diagnosable mental illness, substance use disorders. It's intended to step in before that and to help people find the resources that they might need. If they need higher levels of resources, connecting them to those resources. So with the immediate services program, the first phase, which started back in March when the declaration of emergency was proclaimed, we did a couple of things. One, we launched a bit of a media campaign to help normalize the experience that we are all having. The idea of being physically separated for long distances of time really takes its toll, particularly on seniors, particularly on families who might have been out in doing other things, for people who were employed who are now working at home, for parents who are working from home and now also the teacher of their children. The layers of complexity and challenge just get more difficult. So the first step is to try and create a media campaign to normalize that we're all feeling stressed. And for some people, that might be enough for them to feel a bit better. But if that's not enough, finding a website that would be available at calhope.ca.gov will get you some resources that will provide apps and tools. And one of those is a playbook from the Surgeon General that's available in 8 languages to be able to help people manage the stress that they are feeling. And if the website isn't enough, then we added one more level, and that is our CalHope Warm Line, a call-in number at 833-317-HOPE that people can call and get some assistance from someone with lived experience who can help them navigate what they're feeling and assist them in finding the resources to feel better. So the challenges that we hear from people who are calling the CalHope line are things like, my job is in jeopardy. I may get laid off, I may get furloughed. I'm not sure if I'll be able to maintain my housing. I'm not sure if we'll be able to maintain food in our house. So the combination of housing instability, food insecurity, all add up to stresses that we have never as a society had to face at this level for a very long time. So our hope is that CalHope can assist in making those connections. And those connections are not just at the state level, but they're at the local level. They connect to county behavioral health services. And as we take a look towards the next phase of CalHope, we're anticipating a significant investment from FEMA through the Substance Abuse and Mental Health Services Administration, or SAMHSA, to be able to expand our efforts. And one of the areas of expansion that may be of particular interest is CalHope support. So almost an EAP style of service where someone could make a relationship with a crisis counselor who will likely be a peer with lived experience and have up to 6 sessions with them to be able to establish a more normal way of life and to navigate through these challenges. So we have approximately through CalMesa, our joint power authority, to be able to do grants to local community organizations to engage pods or teams of crisis counselors and supervisors who can reach out to support people in their community who look like them, who trust them, and are able to help them. So in the next couple weeks, we anticipate that we'll get the notice of award from SAMHSA. We'll be able to do a request for application to communities to participate in the CalHope support program. And we hope that all of you will be thinking about whether this is an appropriate way for you to be involved, to build the core set of competencies of peers, such that at the end of this 9-month period of time, the 550 or more peer counselors, crisis counselors, will have had a common experience and be able to enter into the workforce and assist in ways that we had never thought we would be able to do so. So we're excited about the opportunities. I'm excited to be able to answer any questions and excited just to be a partner with NAMI. Jessica, thanks so much for this opportunity.
Thank you so much, Jim. And I know how much work you guys have been doing to respond not only to the SAMHSA grant, but the FEMA grant and really getting CalHope up and running. And again, taking advantage of peers and our lived experience as family members and loved ones. So I'm excited to hear about that SAMHSA opportunity. I think that a lot of our NAMI folks, and especially our NAMI affiliate leaders, will be very interested in connecting and partnering with you guys on that project. So if you have any questions, if you want to go ahead and go to the Whova app and submit your questions, we'll get them to Jim. We have about 10 more minutes with Jim to talk about that. But I wonder if you could expand a little bit. You talked about the website and you talked about the call center. Can you tell us, just in the small amount of time, and you may not have the specific number, but how many people have accessed that call center, even just since COVID has happened? Have you seen an increase?
Well, there's certainly been an increase. One of the issues with call lines is we have a lot of them. So there is a state COVID line, there is our CalHope line, counties have their own lines. So it is a benefit that people have many choices. Yeah. So with the CalHope line, we see anywhere from 100 to 200 calls a week during that Monday through Friday limited hours. So we're getting some traction, but we're also getting many more people coming to the website. So the website traffic is significantly higher, which might indicate that the website is doing its job of giving people some resources that they may not need to call. And then we're also getting a huge number of observations on our digital media. So it's interesting that we have millions of hits when it comes to digital through our media campaign. We have thousands of interactions on the web, and we have hundreds on the call line. So it may be that the program does a little bit of what it's intended, of taking care of people's needs at the lowest possible level.
Yeah, and that's what you hope, right? Is
that was the intention, that would. And then the thing we didn't mention on is that while CalHope is focused, and we spoke here about the COVID and the public health emergency, parallel with that, we are implementing immediate services programs in 10 counties for fires. So those fires and those individuals who have been displaced are...
Oh, you cut out there. Your mic cut out. So you talked about the fires and how you have 10.
Talking about the fires, yes.
Yeah, there you are. Good.
There we go. Sound like there was a motorcycle in the background. Sorry.
That was probably mine. That's probably mine. I have a couple questions.
Please bring it.
How is quality assured, and what makes a crisis?
Well, two questions. Quality is in the training. So when we think about our warm line, there's extensive training that goes in before someone is ever able to handle a phone call. So there's at least 40 hours of training that they do, another 20 hours where there is someone with them on those calls before they can ever handle a call on their own. And then there's screening to even get into the training. So that is the beginning of the quality on the warm line. And then the question on what makes a crisis, great question. Is that an individual crisis? Is that the declaration of an emergency? It is a crisis to the person who's experiencing it if they believe that it's a crisis. We're never going to intervene and say, no, you're not in crisis. If you're stressed, if you're anxious, if the experiences you're having now put you at distress and make it difficult to do your daily activities, that's a crisis. If you think about how government declares a public health emergency and a crisis, that's a whole nother discussion. But I think we're really speaking here about when is the right time to pick up the phone and call. And it's the right time to pick up the phone and call if you think it's time to pick up the phone and call.
Good. And so, yeah. I have a bunch of questions coming in. We could have probably had you for a little longer here. But how, if somebody's interested in becoming a part of CalHope, maybe they're already a counselor within another crisis text line or another call center, how do they apply to become a person for this CalHope?
There's two ways. One, if they were interested in becoming a warm line counselor, then they would be talking to the mental health services program in San Francisco. So we can put my email up and they can email me, and I'll make the introduction to Mark and Raina and the folks there and get them the website, and they can apply to be hired as a warm line counselor. And the beauty of this pandemic, if you look for a silver lining, is that we're now working remote. So you no longer have to physically be where the services are housed. We're able to employ and hire crisis counselors in warm line, no longer just in San Francisco, but anywhere in the state. So we'll be happy to do that. And then the second is if they're interested in the CalHOPE support, that RFA will be going out through CalMesa. So again, sending me an email. We would not be hiring individuals. We would be hiring and contracting with organizations who in turn would be hiring the individuals. So just a distributed model of how we would work.
Wonderful. And we have maybe time for one more question. I got a lot, and if honestly, if we didn't answer your questions, we can send some of these to Jim, and maybe Jim can answer them, and we can put them on our website as an FAQ.
Sure.
What do you think is the hardest part about connecting the state need with local community needs?
Well, the biggest challenge between connecting state and local is the attitude that we're from the state and we're here to help. How many times have we heard that we know better because we're at the state level? And the biggest challenge is communication and listening. The other challenge is understanding California's structure as 58 distinct counties, and we have endorsed a county-driven system of care. So we give autonomy and authority to counties while trying to manage with a single state authority, and that becomes complicated. So we try and come up with guidelines. We are held accountable to federal regulations and funding restrictions, and yet we try and make sure that local programs have the flexibility that they need. How often have we seen wonderful programs that are, quote, evidence-based be thrown upon a community and told they have to do it when it isn't culturally appropriate for that community? A lot of times our evidence-based programs are based on evidence in a community very different than the ones we try to apply these programs to. So our hope is that we start to do a better job of really understanding the uniqueness and the abilities of communities to heal themselves with good tools. So I like to think more about principles and practices rather than programs. And if we follow good evidence-based strategies with the right people who are trusted in those communities, we get to much better results than if we get the 5-star evidence-based program and dropped into a community where it doesn't fit.
You know, and that's a great transition to our next two speakers, but it's also not different than the conversation that we had with Dr. Sheeran from LA Department of Mental Health yesterday, which was, you know, the state really should put outcomes and then let the locals drive how they're going to meet those outcomes. And then how can we, as state organizations, help assist and be of support of our affiliates or our local counties in making sure that families are being served. So Jim, we had a lot of questions, so we wish we would have had more time with you, but it's a great segue to introduce our next two speakers, which are two executive directors of NAMI. Thanks, Jim.
My pleasure. Thank you.
Look forward to continuing our work together. So Chris Roop is our executive director of NAMI Fresno, and she's also on our executive board of NAMI California. And we also have Dr. Cervantes from NAMI Solano, who's the executive director there. I'm going to welcome the two of you. And they're going to talk a little bit about how they're responding to disasters and at the local level. So go ahead and I'll turn it over to both Chris and Dr. Cervantes.
Hi. Oops, wait a minute. Oh. Hey. Oh, wait a minute. Stopped. I'm trying to get on video.
I hear you. There you are. Hello.
Hi. I have to say wonderful, Jim, because I was thinking of the 3 things that NAMI Solano are doing, and definitely we're updating our website to have more resources and more access for everybody to be able to access and to be able to go to other resources. He also talked about resource phone line. We have a wonderful resource phone line that people can call, and we're updating the resources for them to be able to access. And then outreach. I know that NAMI Solano is doing a lot of face-to-face outreach, a lot of phone call outreach. During Mental Health Week, we brought in our partners, Solano Pride. We brought in American Federation for Suicide Prevention. We also are looking at engaging more family-to-family connections with our family-to-family connections in our connections meeting. I can say also with just our own team, we have been affected by the fires and by the pandemic. So with that, we're also doing some training and some outreach for our own team members and looking at our cultural humility to be able to reach our different people out in Solano County. Solano County reaches all the way from Dixon to Vallejo, and we have probably over 50 or so languages and different cultures. So we're also updating ourselves and getting ourselves more in tune with our people that we need to reach. I myself worked with the Center for Our Mindfulness with the Sonoma fires. So I have reached out personally to the firefighters and to the police force to be able to partner with them with NAMI Solano. I think that's important. And also with our Project Room Key with our homeless population, we are working on that with looking at reaching them and to let them know that we're there to support them. I think it's important that I heard Jim saying that even though with Cal Hope that the state is giving us some tools, but only we as the NAMI Solano really know our community and know who we need to reach. And we're really vigorously going out there and connecting with different resources. I'm calling different resources and different organizations to be able to connect with so that we're not so fragmented, that NAMI Solano is a part of a team and an organization that works with all the resources for all of our people in Solano to be able to get the support they need. And I loved what Jim said, a crisis is a crisis. We have many crises that are going on right now, but we want to keep that vigorous, I think, fast pace going for our people in Solano and beyond, because I heard him saying 9 months. A crisis, when somebody has that, it can be years down the line. So for us, I think that's something that we're coming together and to be able to do that. We're also, as our board and myself, we're getting together to look at our strategic plan. How can we rebuild that to be able to reflect, to service the people in our community with the needs that they have? That's some of the things that we're doing.
Wonderful. Wonderful. Thank you so much. We'll hear from Chris and then open to, again, some questions for the both of you.
Yes, I'm going to echo a lot of the things that we've heard both Jim and Dr. Cervantes mention about the connecting to the community partners that are already doing much of the crisis work. letting them do that, but finding out, are they seeing any gaps and needs that we might be able to fill, checking in with our own team that do, they live in the mountain area, and they are a very close group, and some were deeply impacted, but they were able to stay connected and be resources for each other. And yes, we're very aware that while this is a very fast-paced crisis that we're seeing now, we've been experiencing the pandemic for a while. And we, in our local affiliate here in Fresno, started to get a lot of those comments we heard Jim mention. I'm concerned about my housing. I'm concerned about my employment. I'm concerned about the well-being of my children because they're in a different environment and I'm having to work in the home environment as well. I'm concerned about food, whether or not I can provide for my families. And so we saw many people reaching out for resources that typically have just not needed to have peer support, not really needing to have anybody there just because things seem to be healthy. So we were very, very happy to be part of a working partnership with our Workforce Connection group here in the Fresno area. And we started to participate in an outreach that they were doing weekly for those who were impacted from a job security, whether it was them personally or someone they knew, or even as employers. And what we did, it wasn't necessarily to extend NAMI resources to anyone specifically, although that was always an option. It was really to have mental health as part of the conversation for people who were experiencing any changes. We all know when we're mentally healthy, we think clearly, our emotions are quite balanced, and we navigate challenges in a reasonable amount of time, and we act like ourselves, we feel like ourselves. But when things start to change around us, our mental health can slip so quickly without us really being aware of that. And I really was passionate about that because I know that was a change for my own wellness at one time. And so making sure that we kept mental health and the importance of it as part of the conversation, we were already in that dialogue and that pattern when the Creek fires started. And so we got to continue to be connected to our partners. We got to continue to make sure that we were having a basic conversation that can slip so easily. And we were a constant reminder for the community about the importance of good coping, connecting to the support, credible information from credible sources, taking breaks from that flood of information, but also being able to reach out and ask for the help that may be needed. And not only were we doing that for the residents in the community, we're also being a support for our first responders as well, and reminding them to connect to their resources that they have available to them, whether that be EAP, whether it be their peer support within their own agencies, but they're being impacted as well. Some of it's concern about security with jobs going forward. Some of it was the impact of the virus itself. Some of it is impacted by the fires. We've heard firefighters have been out doing their job, but have lost their homes in this. But some of it is because they aren't able to take a break. Their shifts have been longer and extended, but the importance of their wellness in order for them to endure that was really needed to be continued as part of the conversation. Without that, we may forget. It's very easily that we not put our own wellness and our own priorities because we're overwhelmed with a lot of things. And the reminder to many people in these conversations is things are changing fast, things are unexpected. There are things we cannot control in what's changing around us. And so it's very, very important to maintain our wellness through this as best we possibly can, because I know that's easier said than done. How do you tell someone to get rest when they don't have their home to rest in? How do you tell someone to rest when they have a loved one that they can't have access to because there's a barrier for them, whether it be COVID restrictions or distance restrictions now because they've had to change their location due to the fire. So I don't share those things from a frame of mind that I'm naive, that it's easy to do. I just believed, and all of us on the team here in NAMI Fresno believed that needed to be constant dialogue that was happening because we were in a healthier place to remind our community members, our peers, our family members, and our first responders in this work why they matter so much and why they need to take care of themselves to navigate through all this and have the best possible outcomes, that we get through it and that they're not alone through this.
I agree. I think that's so important for us to remember that we take care of ourselves and remind everybody that mental health is taking care of your health.
Yes.
I think that's so important, that they're so intertwined, and it's a holistic approach, and NAMI really believes in that, and that permeates with that. The other thing that I know that we're doing is we're starting to connect to the schools. As a former teacher and principal, I cannot say how important it is because our students are now out of the schools where they were having that place where they could go, be it whatever it is. So we're starting to connect with our Solano County Office of Education. And I connected with some of the principals that I know and say, what can we do to help? I think that's so important because our youth is, I think as, I don't know if it's Jim or they said 1 in every 4 are looking at suicide at this time. And that is not okay. We need to help them, really.
And asking the question, and we encourage the community when they're extending support as well, because everyone wants to do something to contribute to helping the community come together, to feel supported and have their basic needs met. But what I've encouraged them to do is to ask that question, but not expect an immediate answer back. When you are impacted by the depths of these crises, such as the fire or even the pandemic, we don't always know what we need. We aren't able to always articulate it. And a lot of us are not in a frame of mind that we're used to asking for those different types of supports that we need. So I've encouraged people to continue to ask, continue to check in. We're all there in the beginning of a crisis, especially our fires and the beginning of the pandemic. How many of us are still reaching out and asking, how can I support you now? Because our needs are changing. We may have been able to adjust early in the beginning, but now as time has passed, do we have a different need? And no one's asking how they can support us as time goes on. And hearing that 9 months from now, we're still going to be extending support and needing support, we know that may be even longer. And so we want to make sure we have, as Dr. Cervantes said, our team needs to be refreshed and trained so that we are prepared to extend the support that we want to, and we know we do really well, but are we ready to give that? And do we have people who have the skills in the platforms we need to do it? We're all making those adjustments, and just keeping ourselves refreshed, keeping ourselves humble, and keeping ourselves healthy is important as well, so that we continue to be part of solutions and part of resources and part of our community collaboration.
Wonderful. Thank you both for the work that you're doing. I have a few questions that have come in. If you could keep one thing in the current crisis that we're in, and you hope to continue forward as a part of our normal part of addressing the need, what would that be? Either one.
I'll go. I do hope we continue to keep the virtual platforms as an option, because we know we've reached a population that has not had easy transportation, that's not comfortable sitting in space with others. There's a convenience to it for some. There's a need that some have just to ease their own wellness and removing those symptoms of anxiousness for their physical presence. And so I do hope that we get to continue to keep our virtual platforms as an option in the work that we're doing. But I miss the human connection, and I know if I'm missing it, I'm not alone. So I hope that we blend those. I hope we, just as distance learning for our students, will have blended options. I hope that we continue to keep blended options available for the communities that we're serving.
I would say also, I would like to keep, as everybody says, 9 months. 9 months is not a time. To make sure that we, and I love what you said about checking in with people and making sure we're continuously doing that. I mean, Hurricane Katrina, I know some people that were affected by that, and that's still in their minds and still in their emotional state. So we need to really keep that connection. And I think we need to keep blending our mental health with our physical health. And I think if we keep anything, we need to keep partnering with our physical health networking and making sure that it is blended in a really consistent, holistic way.
Great answers. And then one more question. If you could wave a magic wand and change one thing about how we are addressing crisis in our communities, what would it be?
My magic wand would be to have access to more placements for individuals who truly need it. That would be my magic wand wave, more placement availability for those experiencing crisis.
I would say the same, access. I just, from my previous experience, I worked with Project Roomkey in Yolo County, and we had over 100 homeless people that were there that we were working with. And it's like, we have to have access. We have to have, and like you were saying, virtual, we have to have virtual access. But virtual access, we have people that can have that. So we need to have virtual access on wheels that can go to people and to meet them. I mean, even myself, I was going in different parts of the city just to find people to let them know I'm there. So I think that's what we need, is virtual access on wheels, have laptops that they can, you know, connect to people, have different things. We worked with Communicare in Yolo County, and they had a medical staff and a mental health staff all on wheels that went throughout West Sacramento to help people. So I think that's what we have to continue that, because people aren't going to kind of change their access. We have to change how we access them. I think that's important.
Meeting people where they're at with what they need, right? Well, thank you both so much for the work you do. I know you both are very, very busy, and we couldn't be NAMI without each and every one of you here on the call, but also with your leadership locally.